morning, everyone. Thank you for joining us on episode 11 of Breakfast at UMHealth. My name is Jamie, and I'll be the moderator of the first session today, From Crisis to Clarity Clinical Debriefing. This is a topic that is incredibly relevant to all of us working whether in acute care, perioperative medicine, ICU, or emergency settings. In the fast-paced, high-stakes world of healthcare, we often move quickly from one critical event to another without even a second look. However, research shows that structured debriefing can improve team and individual performance by as much as 20 to 25%. Today, we are exploring how to transform these learning conversations into a standard part of our clinical culture. We are honored to have Dr. Gobinath Antoney Das with us. Dr. Gobi is an early career lecturer in the Department of Anesthesiology and Critical Care. He completed his Masters of Anesthesiology training here in University Malaya in 2024 and has many years of experience across multiple tertiary centers in the country. His interests include resuscitation and crisis management, medical simulation, and regional anesthesia. He'll be guiding us through the what, when, who, where, and how of effective debriefing, from immediate hot debriefs to the more reflective cold sessions. Dr. Gobi, the floor is yours.
Hello, good morning, everyone. So, without further ado, I will start with our presentation today. So, we'll be talking about clinical debriefing, what it is, why it matters, and when we should be doing it. This is an important topic, like Dr. Jamie has introduced earlier. So, it's because healthcare teams face high-stakes situation every day: resuscitation, airway emergencies, unexpected deteriorations, and deaths. So those are the technical part of it. There are also non-technical issues which we face, which includes communication failures, near misses. So these events do not just end when the patient is stabilized or when the patient passes away. They actually leave behind lessons, unanswered questions, and also sometimes an emotional impact. Okay, so this slide actually shows a roadmap for the session. So I'll move through the topic in a practical sequence. So first, we'll talk about a brief introduction, then the 5E framework, and then when to debrief and when not to debrief, because we know when we debrief at the right time, it actually provides an impact. When we debrief at the wrong time, it can actually produce a negative impact on a person. So then we'll talk about the debrief intent. There are 3 different types of debrief, which includes debrief to learn, debrief to manage, or debrief to treat. And types of debrief based on when is it done, whether it's a hot debrief, warm debrief, or cold debrief. Barriers which we face, voices in the room, which means which participants should be taking part in debriefing sessions. And lastly, a few clinical debriefing tools which may be practical in our daily work. Okay, so let's begin with some introduction. So basically, debriefing is a post-experience analytic process that occurs soon after a clinical event. It converts experience to learning. So it's interactive, bi-directional, which means involves communication between the facilitator and also the participant. It's important to note that it's different from feedback, which is more of a one-way thing, whereby it involves one person telling another what was done right or wrong. Another important thing to note is debriefing is not therapy. It may acknowledge emotions and normalize distress, but the main purpose is team reflection and learning it. So if someone is significantly distressed, they may need a different type of support. So debriefing actually involves these 3 headings, which includes discussion, reflection, and analysis of an event or experience. So, for example, after a difficult intubation, a debrief is not just the consultant or specialist actually telling the registrar what went wrong. It's a team discussion involving everyone actually telling their input. Was the airway rightly predicted before the attempt? Was the equipment ready? Was the communication clear? Did we escalate to intubation early enough, or were we trying with NIV for some period of time? And what should we do differently next time? Okay, so a good clinical debrief involves a few criteria. First would be asking all the participants, are they all right? This actually sets the scene, allow everyone to actually vent out before we go in a more detailed discussion, and then ask what has happened and why has it happened. and discuss about what went well, what could be improved, and what should be done differently next time. It doesn't need to be a lengthy session. 2 to 3 minute or 5 minute session would be enough actually. So debriefing is almost similar to the one that a crisis debriefing is almost similar to the one we do in simulation, and is considered a core learning activity. Okay. So this slide actually introduces the historical roots of debriefing. Basically, it evolved from military after-action reviews, whereby in World War II, the military officers actually reconstruct events accurately, review mission conduct, and inform future strategy. Initially, it was to find whose fault was it and all, and later on they moved away from it, and it was more of a productive session to improve teamwork and better success of missions. So this actually was brought into aviation. Aviation safety failure accelerated attention to communication, teamwork, and human factors and resource management. They called it crew resource management. Okay, and then this was later brought into psychological debriefing, whereby critical incident stress debriefing was created. This is to manage high-risk occupations such as police, firefighters, and first responders, who actually have may be prone to be stressed in work. So and later on, this was brought into medical education by David Gaba, which translated it into crisis resource management. Till now, we actually use this in our medical simulation educations. So this study is actually a multi-center cross-sectional survey of emergency medicine attendings and residents from 4 large academic residency programs in New York. So actually, they actually studied on how clinicians perceived the usefulness of real-time debriefing. So most of them said that it was very beneficial to clear the air after an event, provide feedback to learners and colleagues, identify knowledge and process gaps, identify system errors, promote team unity and cohesiveness, and identify medical legal ramifications. So let's talk about the 5E framework. Okay, I personally like this framework because it reminds us that a good debriefing is not just technical, it's also human. That means it needs structure, but there's also a psychological safety element to it. So the 5 E's are educated or experienced facilitator, which is a trained and experienced leader to guide debrief. But now this is no longer necessary because we have these clinical debriefing tools to actually help us. But when everyone goes for the modules and things, and become experienced in debriefing, is actually quite beneficial. Environment, safe and respectful and confidential space. Education, meaning that to clarify what has happened and reinforce it into clinical learning. Evaluation includes identifying strengths, gaps, and improvements in actions. And emotions, acknowledge emotional impact and arrange follow-up if needed. So this is normally the first thing that we do. We ask if everyone is all right. Okay, so debrief smart, when and when not to debrief. So most of the time when we say debriefing, we associate it with catastrophic events such as cardiac arrest, respiratory failure, hypotension, deaths, adverse events, near misses, and the non-technical issues such as conflicts, communication breakdown, teamworks, adherence to guidelines, technicals, and procedural issues. But it's also important to note that debriefing should be done not only for those dramatic disasters, but it should be done routinely. Why? Because it normalizes reflection, reduces stigma and builds culture, and help teams to learn from both success and failures. If we only debrief those catastrophic events, the process become associated with blame and crisis, meaning that when we say we're going to debrief, our staff will probably think that they've done something wrong, and because they associate it with blame and crisis. So if we debrief in a routine case, it becomes part of a normal team learning. So whether it's for success or for failures, both we debrief, it becomes a routine activity of the team for the purpose of learning. Okay, so when not to debrief? A debrief may not be appropriate when there's severe emotional distress, because this actually causes a risk of harm. Immediately after traumatic events, unsafe environment, for instance, safety of our own patient, that particular patient, or safety of other patients are compromised, or if there's a risk of frequent interruption during the debriefing section. And then if it's blame focus or legal context debrief, it's also not advised to debrief yet. And it's very important to note that debriefing session is not a substitute for root cause analysis, audits, mortality and morbidity meetings, and also when psychological support is needed. Okay, so examples of debriefings. So during COVID-19, and ED actually implemented a remote 10-minute structured end of shift debriefing to actually encourage learning and also reflection. And then there's also debriefing after falls to learn and prevent further falls. And PICU actually started holding up interdisciplinary debriefing several days after cardiac arrest to review key resuscitation metrics. And AHA specifically recommends debriefing after CPR to improve rate of ROSC, neurologic outcomes, and hands-off compression time, and also time delay to first compression. So this example which I provided is actually all those dramatic sort of debriefing. What I'm trying to say is those we should bring it to as a routine thing so that we don't do it during events only. Okay, so this article actually triages that the debriefing into 3 different categories based on the intent. So broadly, a debriefing can be classified based on the aim, which is either debrief to learn, debrief to manage, or debrief to treat. So how do we differentiate these 3 debrief? So normally we do debrief when any participant actually said, ask the question, shall we debrief? So then that's an indication that we should be debriefing. So then we look the purpose of the debriefing, whether it's to reflect on how we work together during the resuscitation and to improve ourselves for the next time. Then it's a debrief to learn. But if it's wait, can we sit down and talk for a while? It's likely a debrief to manage. So we probably have to investigate further whether anyone requires additional supports. And so if they require additional support, then we'll have to consider to actually consult a mental health specialist, either a psychologist or psychiatrist, to help us with the debrief to treat. Because it's not recommended for us to do a debrief to treat if we don't have the experience and the skills. So instead, to provide debrief to manage actually able to find enables us to actually find those in need of this debrief to treat. So as for debrief to learn, it actually explores experiences in detail. So we can use structured approach such as thought, pearl, and reflect. And the structure is actually similar to the one that we've discussed earlier. So we create a safe learning context, share initial reaction, clarify facts, explore a variety of performance domains, and identify takeaways. So hot, warm, and cold. These are different types of duration with which we debrief. So hot debrief means we debrief immediately after a crisis or event. Warm debriefing is minutes or hours after the crisis or event. Duration is for both of these debriefing is usually around 5 to 10 minutes, meaning that it's a short duration debrief. Meanwhile, cold debrief is is usually held days and weeks after crisis or event. The duration is actually an hour or longer. Okay, so cold debriefs are best viewed as a complementary to hot debriefs. The benefits of cold debrief: more data can be collected, additional staff will be able to attend, expert facilitators will be available to be attending and give their input, and then staff also would have had a longer period to actually reflect on the event. So the minus points with a cold debrief: these events may not be clearly recalled by participants, immediate support for the staff is not provided, and learning from the event may be delayed. So hot, warm, or cold debrief, which one should we use in our practice? Most expert actually recommends hot debrief. So everyone is already at the scene. It has a lesser recall bias, and there's a higher potential to quickly address any issues. So, and later we can just schedule root cause analysis, system function, and process improvement to actually at a later date after the event. So barriers to debriefing includes lack of proper guidelines for everyone to follow, lack of a trained facilitator, for instance, in the early morning, you may not have a person who is actually able to facilitate this. Workloads, we may be too busy with attending patients continuously, so everyone feels that this actually becomes the least in the priority. And then lack of time, psychological factors, lack of appropriate space. For instance, to protect confidentiality and all, sometimes you need a proper safe space to actually voice out your thoughts and emotions. And then lack of admin support. So this is an interesting editorial review titled Stop Asking If It Works. start making it happen. So it actually explores the similar barriers in 4 different headings, which includes clarity of purpose, time, skills, and culture. So clarity of purpose, some staffs actually see debriefing not clearly beneficial. So the suggestion, we probably can include it as a quality improvement process while acknowledging the benefit for well-being, team connection, and sense making. And then later on, the second point is actually time. So busy workflow actually makes the staff feel that they don't have enough time to debrief. What they suggested is actually to keep the debrief short, 5 to 10 minutes, acknowledge competing demands, and do not wait for everyone to be present. So even for instances which are not recommended to debrief, actually you can just do a short debrief just to see if everyone is all right, to set the temperature, and then probably attend to, it actually helps us to find out if anyone needs help so that we can address it faster. So many staff often feel underprepared to lead and participate in debrief. So what they've suggested to use simple structured tools, identify local champions, and also provide either online modules or supports. And cultures. Hospital cultures may prioritize incident investigation over routine learning with limited leadership support. So it's very difficult to change a team's particular culture. So making debriefing a part of a developmental priority supports it with time and resources, and also act on the feedback being raised is actually quite helpful. Okay, so who should participate in debriefings? So basically, those who are involved in the events, doctors, nurses, allied health staff, this matters because different people actually saw the event in a different point of view. For instance, a nurse may actually identify the medication flow problems. The doctor would probably remember decision-making challenges, and a medical assistant probably may notice communication failures and equipment issues and medication errors as well. So the key idea is debriefing is a multi-professional learning process. If only seniors speak, the team will actually lose valuable perspective. So this is why psychological safety actually matters so much. Inclusion is not just people who are physically present, or but also involves those who actually feels the need to speak. So it's important to identify a facilitator to actually make the smooth flow of the event, of the discussion. Okay, so basically a clinical debriefing is a learning process for everyone. Any member can actually facilitate with proper guides and tools. Potential to inhibit or bias may be present due to hierarchical issue. So adding a co-debriefer actually may help. Okay, so the role of a facilitator would be to facilitate, not dominate the conversation. This is not a lecture of what was done right or wrong. And then when we debrief, we actually ask open-ended questions, and then practice self-restraint, limit statement of your own opinions, and a good facilitator would empower others to speak up, offer honest opinions and observations and suggestions. It will be a non-punitive conduct and create an atmosphere of psychological safety, and also keep the conversation brief and avoid tangential conversation. So example of phrases that we can ask during a debriefing would be, what has happened from your perspective? What would you think actually worked well? And what difficulties did we face? And what other things we should repeat next time? And what one thing that should we change? Probably ask everyone one question so that we can actually minimize time and everyone could actually give a different answer. Okay. So should we standardize how we debrief, meaning that using a particular format per se during each debriefing session? So yes, because basically the advantages are team members actually anticipate a debriefing for every particular event that requires one, and then it aligns the developmental goals. And when we have a structure and standardized practice, it actually increases the debriefing frequency. So last, we'll talk about a few examples of clinical debriefing tools. So plus delta top 5, there's actually a lot of it, a whole list of it. Pearl, top, reset, eras, discern, info, and reflect. So this is a systematic review of 21 studies from 5 different databases, which explored acute care settings. So they actually use this 5E format to examine each tool. And what they found out was debriefing tools are actually useful for structure and psychological safety. the evidence for downstream change and patient outcome is still limited. But we all know that what do you call, we do not, I mean, it actually works. So basically, we don't have to wait for evidence per se to, probably more studies need to be done to actually provide evidence on its benefits. Okay, so this is the most easy clinical debriefing tool, one of the most easiest ones. So plus and delta. Plus basically means what went well, and delta basically means what needs to be changed and how to change them. So we need to be specific, focus on actions and system-related issues. Then the second one would be stop five. Stop five, similar to all the other clinical debriefing tool, actually we check the team first. Is everyone okay? Then we mentioned that we are going to have a 5-minute debrief session. The purpose is to improve quality, and this is not a blaming session. The participation is welcome and but not compulsory, and then everything is confidential. So this actually provides a psychological safety for everyone to voice out what they actually feel and their emotions are. So then after that, someone summarizes the case, and then everyone starts talking about things that went well, opportunities to improve, and points to action and responsibilities. Okay, all of it will be done in 5 minutes. That's why it's called stop five. Okay, next would be pearls. Pearls actually come from a simulation-based debriefing. It offers useful principles of for healthcare debriefing. I personally like pearls because they actually provide sample of phrases. For instance, when you want to set the scene, they actually provide those sample of phrases. So when after a particular event, when everyone probably is emotionally and mentally exhausted, we actually have these samples of phrases at the side. So it follows the same sequence, setting the scene, reaction, description, analysis, and at the end, application of summary. Okay, so as for the analysis phase, actually they have different domains. So based on one particular event, actually the clinical debriefing session can be focused on various domains. So for instance, that means each debriefing session could be a different thing, even if you do it on a routine basis at our daily practice without a dramatic event. So can actually explore decision making, technical skills, communication, resource utilization, leadership, situational awareness, and also teamwork. Okay, so the conversation technique in so there are 3 approaches in healthcare debriefing, which includes first would be the learner self-assessment. Then this actually provides a focused reflection of the learners to assess their own performance, and then facilitation by the facilitator so that the facilitator can actually probe a deeper aspect of the performance. And last would be the facilitator to actually provide information to teach to close the clear knowledge gap as they emerge and provide the directive feedback. So as you can see, the focus facilitation actually involves this advocacy and inquiry. So probably you can say the facilitator can actually say that I saw you were doing this, and then I'm thinking of a particular point, and then inquire the participant, how were you actually seeing it at that time? For instance, there was a delay during resuscitation to actually start a second vasopressor. So the person can actually ask the participant if there were any factors involving, actually making them delay in starting the second vasopressor. So probably they wanted to try some more fluid resuscitation first, or they felt that the patient was actually in fluid deficit instead of requiring vasopressor. And then so we probably prompt and ask instead of being judgmental why they did that. So we ask open-ended questions. So what was actually running down in their mind, so that to show that we are not judgmental, but we are just curious. Okay, so talk similar to the earlier formats. So target, analysis, learning point, and key actions. So they actually conducted a interventional study, and then found out that teams were more likely to debrief. Then there was planned action improvement, and more nurses and allied staff initiated and led debriefs. So this is actually this is a form that is used in Texas Children's Hospital emergency room for debriefing sessions. Okay, so what does a successful debriefing looks like? Team members feel secure in critically analyzing their own performances. All members understand that patient care is collaborative rather than individual, and constantly frame the discussion of suboptimal performance and errors in the context of team responsibility. So a successful debriefing should leave the team with more clarity, shared understanding, and at least one concrete takeaway for future improvement. Ideally, it also leave people feeling heard rather than being judged. So these are my references. Thank you.
Thank you, Dr. Gobi. That was a really wonderful presentation. So I believe we do have some time for questions from the floor. Please feel free to ask any questions or share your thoughts, challenges, or experiences from your own departments. Okay, so maybe while the audience gathers their thoughts, perhaps I can start with a question for Dr. Gobi. Yeah, so if a unit currently has no formal debriefing culture, what would be the single best first step for us to introduce it successfully?
Okay, so if a unit doesn't have a particular debriefing structure yet, so I think I would probably start small and consistently. So when because it doesn't take a day to actually build a mountain. So what we do is we start small and consistently choose a few appropriate cases to actually begin with, and then find an expert to actually debrief with us. So as time goes by, when everyone actually gets familiar with debriefing, then probably we can initiate a quality improvement project. So the first step is always to create an positive early debriefing experience rather than straight away imposing a policy.
Okay, and we actually do have a question from the floor from David Oregon. So he has asked that do you have any idea on the use of any of this in daily practice in our organization? This meaning uh, the tools that we use to debrief, and also depending on the answer, what are the barriers to uptake? I guess the barriers was somewhat like the first question that I asked, but maybe you can share on what are the tools that we use on a daily practice.
Okay. So on daily practice, actually, in previous places which I've worked in during my attachment in emergency departments, actually they actually have this morning prayers where actually everyone go through the on-call team actually goes through whatever cases they actually encountered overnight, and they actually debrief the whole day's activities. But it wasn't actually following a particular structure per se, which I've discussed earlier. And the barriers to debriefing would be actually most of the time is time. So it takes time. It takes a particular what do you call it takes a team collaboration to actually change the practice. So as in like after, if we have enough staffs, probably we can impose a debriefing session when as a routine basis or at the end of shifts, or yeah, most likely at the end of shifts, so that we can actually make it as a routine thing. And besides time, is another factor would be culture. So these two things actually two of the greatest barriers.
Okay, I mean, talking about culture, right? I guess that's one of our major challenge, right? We try to avoid blaming culture as well.
Yeah.
So, I mean, what specific phrases or facilitator behaviors do you think can help create psychological safety, especially when hierarchy is so strong in our Asian culture?
Okay, so first, when we initiate a debriefing, how can we provide a psychological safety would be telling setting the temperature, finding out if everyone is okay, and then start with a brief ground rule. Say that this is going to be a confidential session. Provide respect during communication. Acknowledge that we are here to actually learn and not to blame anyone, and then ask open-ended question rather than being judgmental with our questions. Yeah, so I mean, when you ask questions, make it sound more curious. And then another thing, let everyone speak. So for instance, if you notice that someone hasn't voiced out, then try to actually ask them if they have anything in their mind about it.
Okay.
So for examples of examples of phrases would be saying that probably this is not a blaming game, it's more of a learning purpose. Yeah.
Okay. I believe that's all the time we have for the first session. Thank you, Dr. Gobi, once again for such
Thank
a
you.
practical and highly relevant session. I think the key take-home messages for all of us are, firstly, debriefing is for everyone and should not be reserved only for major crises, because even routine events can offer powerful learning opportunities. Secondly, hot debriefs are often the most practical because the team is present and the event is still fresh. And lastly, a successful debrief is one that creates a safe space where everyone feels secure enough to critically analyze performance without fear of punishment. And perhaps, I guess the most fitting April Fool's Day takeaway today is this. Surprises in medicine are inevitable, but good teams make sure the same surprises doesn't happen twice. That is the real value of debriefing. So I thank you all for your active participation and for your commitment to improving patient safety through better communication. Have a wonderful day, everyone.